Now, let's talk about the predictable pathway from a polyp to a cancer. This is called, appropriately, the polyp cancer sequence. Here's a slide that demonstrates a mutation from normal epithelium on the left side of the screen to full-on carcinoma. Through this process, there are predictable signs of genetic mutation that allows hyperproliferation, forming a polyp, eventually degrading to a carcinoma. Let's look at some of this in detail. First mutation that occurs is an APC tumor suppression gene. This allows tumor initiation. Now, remember, tumor suppressor genes, which we have a lot of, its main job is to suppress overgrowth.
KRAS is a proto-oncogene. KRAS proto-oncogene mutation only causes hyperplastic syndrome, but if it follows APC in this predictable line of mutations, it leads to adenoma. Scientists are still working on why the KRAS in this context leads to adenoma versus the mutation alone that only leads to hyperplastic polyps.
This then progressed to a deleted in colorectal cancer, which is yet another tumor suppressor gene, and finally the P53, which leads to apoptosis. Mutations of P53 then allows a cancer phenotype. Let's review for a second another question. What's the difference between Lynch syndromes 1 and 2? I'll give you a second to think about this. That's right, Lynch syndrome 1, again, is a familiar colon cancer without extracolonic manifestations versus Lynch syndrome 2. It's associated with other cancers, particularly of the GI and reproductive tumors. Amsterdam criteria is an important set of criteria for the diagnosis of Lynch syndrome, or hereditary non-polyposis. This is the classic definition of 3 relatives with colon cancer over 2 generations, at least of one of which was diagnosed at a fairly young age. There have been subsequent iterations of this diagnosis, but the bottom line is fairly similar in that we want to see multiple young people diagnosed with colon cancer in a family over multiple generations, suggestive of, number 1, a genetic mutation, and 2, potentially an autosomal dominance. Here's Amsterdam criteria number 2. Amsterdam criteria number 2 liberalized the definitions a little bit. Here, the requirement is that there should be at least 3 relatives with any Lynch syndrome-associated cancer, be it colorectal, cancer of the endometrium, small bowel, ureter, or renal pelvis. One should be a first-degree relative of the other 2, at least 2 successive generations, much like the original definition, and at least one should be diagnosed before the age of 50. Again, very familiar to you. Remember that FAP should be excluded in colorectal cancer cases. Tumors should be verified by pathologic examination. Yet another criteria called the Bethesda criteria is also used for Lynch syndromes. In the Bethesda criteria, colorectal cancer diagnosed in a patient who is less than 50 years of age, there has to be presence of synchronous or metachronous colorectal, synchronous or metachronous meaning at the same time or at different times, or other non-polyposis-associated tumors, regardless of age, that the colorectal cancer with a gene repair mutation and a histology diagnosed in a patient who is less than 60 years of age. The colorectal cancer diagnosed in a patient with 1 or more first-degree relatives in a non-polyposis-related tumor. And lastly, that the colon cancer is diagnosed in a patient with 2 or more first or second-degree relatives. Basically, different spins on the same criteria of multiple relatives, multiple generations, and diagnosis early on. What are some physical findings in colorectal cancer? Unfortunately, the vast majority of patients do not have a classic profile of physical findings that would allow us clinicians to detect it early on. That's why screening is so important. Usually there's no pain. Maybe there's bleeding. Maybe a large bowel obstruction. That's why due to colonoscopy, early detection is the most important thing that we can offer to our patient. By the time you wait for classic physical findings of bleeding and obstruction, it's likely that the colorectal cancer has already progressed into late stages. We now consider colon surgery preventable due to screening and because of the predictable deterioration from a polyp to cancer in the polyp cancer sequence.
At this point, it's worth mentioning the difference between left-sided lesions and right-sided lesions. Left-sided lesions are more likely to present with symptoms of obstruction, such as constipation or decreased stool caliber. On the other hand, right-sided lesions are more commonly present with bleeding, macroscopic or microscopic, or iron deficiency anemia. The reason that right-sided lesions do not cause obstruction is that the diameter of the right colon is greater than the left, and the stools have increased water content.
Again, no set of routine labs is indicative of colorectal cancer. One may find a drop in the hemoglobin hematocrit due to a slow bleed. We oftentimes get a CEA or carcinoembryonic antigen both before and after surgery. We don't use it as a screening tool, however, but it is very useful as a follow-up after treatment for detection of recurrences.